Okay, due to interest of time, we're going to get started. Good afternoon, everyone. My name is Priscilla Calvache. I'm the Assistant Director for Lupus Programs and Community Engagement here at HSS. And today I'm excited to partner with the HSS Department of Medicine in honor of Lupus Awareness Month and welcome you all to this important presentation. I'd like to thank everyone joining us this evening and for submitting your thoughtful questions and comments during registration. Today, I'm accompanied by my esteemed colleague, Trisha Doherty, who is the Senior Director of Nursing here at HSS. And Trisha will be joining us now and later to facilitate our question and answer segment.
I just wanted to welcome everyone today and thank you so much for joining. We're really happy to have you join our program and really excited about Lupus Awareness Month. So more to come from Dr. Siegel.
Thank you, Trisha. And before we get started, just some brief housekeeping rules. Participants will be muted during the presentation, but we're highly encouraging you to please use the chat icon to send questions throughout the presentation. We're going to have time to review your questions at the end of the presentation, and Dr. Siegel will also be addressing the questions that were submitted during registration. Lastly, I just want to introduce our program evaluation. Your feedback is really important to us and really helps us to inform future programs like this. So we're going to be embedding that survey link at the end of the talk today, and we ask you to please not leave us today without completing this brief survey. So at this time, it's my pleasure to introduce our speaker this afternoon, Dr. Caroline Siegel, who graduated from Princeton undergrad in 2012, then Weill Cornell Medical College in 2016, UCLA for internal medicine residency in 2016 through 2019, and completed general rheumatology fellowship at HSS, as well as a master's in clinical research through the Weill Cornell CTSC in 2022. She is currently doing a one-year women's health fellowship sponsored by UCB within the Rheumatology Reproductive Health Program at HSS. The fellowship involves clinical training and research related to sexual and reproductive health issues that affect people with rheumatic diseases. Dr. Siegel will be starting as an attending rheumatologist at HSS after graduating from this fellowship. And today we have the pleasure of having Dr. Siegel with us to present on the topic of sexual health, pregnancy, and lupus. Welcome, Dr. Siegel.
Thank you, Priscilla. Thank you, everyone, for being here, and thank you for the invitation to speak to you all today. And we'll just get started. So our agenda for today's talk is as follows. First, I'll give you a brief overview of some relevant background related to lupus and this topic. Then we'll talk about sexual health and lupus. I'll talk to you about family planning and contraception, fertility concerns and treatment in the context of lupus, pregnancy risks and management of lupus during pregnancy. And then I'll provide you with some additional tips and resources that you'll have access to after the talk to refer back to. And I've structured this talk scattered throughout with a few myths and common misconceptions that we'll debunk, and I'll give you some of the facts. So the first myth is that only females get lupus. And of course, this is not the case. However, females are more likely to have lupus than males. And specifically with childhood onset lupus, the ratio of lupus is about 3-to-1 female to male ratio. And in adults, this is more like 7 through 15-to-1. That's the sort of the range reported of lupus incidence in adulthood, female to male. Most people with lupus are diagnosed somewhere between age 16 and 55, which I know is a broad range. When lupus does occur in males, it can often be more severe than in female lupus patients and more commonly affecting the kidneys and other vital organs. And this is also the case with childhood onset lupus as compared with adult onset lupus. But I think the big takeaway from this background information is that lupus is a chronic condition and a really heterogeneous condition, meaning that it can manifest differently for each person affected. And even within a given individual, its manifestations can change over time. So there's no sort of one size fits all in terms of diagnosing or managing lupus, and sort of keeping that in mind as we go through the rest of the talk is important. So getting into some topics related to sexual health and lupus, we'll start with puberty. And it has been reported in about 15% of females and 24% of males with lupus that puberty can be delayed. There's also an association in some patients with lupus flaring in the context of pubertal changes in pubertal development. And of course, this really applies to childhood onset lupus or younger age onset. And this may be related to some indirect factors like steroid use in childhood that can be associated with delayed puberty, delayed puberty, can be associated with steroid use. Menstruation can also be delayed 1 to 2 years overall, like sort of on average in patients with lupus compared to those without lupus. And this is also likely associated with some indirect factors. So longer disease duration and steroid use may contribute. And lupus is also commonly associated with menstrual irregularity. Active disease versus more stable disease. Active disease can directly interfere with menstruation and contribute to that menstrual irregularity. And hormonal changes that occur over the course of the menstrual cycle in some patients can actually be a trigger for disease flare. And there are some potential long-term implications of these associations with delayed puberty and delayed menses, as they can increase one's risk of low bone density, osteoporosis, heart disease later in life. In terms of general women's health and gynecologic issues, some gynecologic problems that are really common in the general population, maybe even more so in women with lupus. So these include endometriosis, which is typically characterized by pelvic pain, pain with sex, painful periods, and having heavy or otherwise irregular periods. And polycystic ovarian syndrome, commonly known as PCOS, which is characterized by having irregular periods, acne. It can be associated with weight gain, excess body or facial hair, and increases one's risk for prediabetes and diabetes. What about men's health? Well, in men, there's some research suggesting an association between having lupus and reduced libido, erectile dysfunction, and problems with ejaculation or sperm abnormalities. More research is really needed to tease out some of these associations and understand the factors directly contributing to these associations. And I want to mention sexual function and dysfunction, as this is a really an often neglected area of quality of life for people with chronic diseases in general, including lupus, both in terms of research attention and clinical attention, sort of doctors bringing this up to their patients or patients feeling comfortable bringing this up to their doctors, but it's an important area of quality of life. And there are many disease-related factors, medication-related factors, and also psychosocial factors associated with having lupus that can contribute to sexual dysfunction, including pain, fatigue, stiffness, functional impairment, and also associated depression, anxiety, and negative body image. And research has shown that disease severity in lupus and especially illness perceptions are associated with increased sexual impairment. Okay, so moving on to our next myth, which is that lupus is contagious. So of course, lupus is not contagious. It's not an infectious disease. It is an autoimmune condition. However, people with lupus may be at a higher risk of developing certain infections compared to people without lupus. And this is both due to the underlying immune system dysfunction that occurs in the context of lupus, and also the fact that our common medications that we use for lupus suppress the immune system, which then increases one's risk of developing certain infections. And since this is a talk about sexual health and lupus, I'll specifically focus on sexually transmitted infections, which are common in the general population, specifically, especially in teens and young adults. Gonorrhea and chlamydia are among the more common STIs, and these may be asymptomatic. So it's important to know that, because in certain people with higher risks, routine screening may be indicated. And it's important to be proactive about communicating with your doctor if you're worried you may have been exposed to an STI or have other risk factors, or of course, if you have symptoms, because it's not always asymptomatic. And there are effective treatments. There are antibiotics that treat some STIs that are bacterial, so gonorrhea, chlamydia, also bacterial vaginosis, trichomoniasis, and syphilis, and then antivirals, which can treat viral STIs, including HIV, herpes, hepatitis B, hepatitis C. And a consistent condom use is the most important preventive measure for decreasing one's risk of developing an STI. HPV, another sexually transmitted infection I'll highlight and sort of give its own spotlight because there is actually a myth, common misconception that HPV vaccination can cause lupus. And so it's important that we debunk this. So what is HPV? HPV is human papillomavirus. It's an infection that's transmitted during oral, vaginal, or anal sex. HPV typically does not cause symptoms, but it is the cause of the vast majority of cervical cancers. And it also is an important cause of anogenital warts, vaginal oropharyngeal, so oral and throat, anal and penile cancers. An HPV vaccination has been shown to be safe and effective in people with lupus and has not been associated with causing lupus or lupus flare. More on HPV prevention and screening. So there are recommendations in the general population that everyone be vaccinated against HPV with at least a 2-dose vaccine series. And there are some indications for a 3-dose series in people with certain risk factors or with delayed dosing. And then in addition to HPV vaccination, which is an important preventive measure, Pap smears are also recommended for all women starting at age 21, regardless of risk factors. And for people with lupus, the recommendation is slightly different, where we recommend yearly Pap smears for the first 3 years. And then if those have all been normal, the interval may be spaced out, but this may be individualized. But it's worth noting that there's guidelines that are slightly different for people with lupus than the general population because of an increased risk. And then some abnormalities that may be identified on Pap smear may require further procedures. Okay, now we'll spend some time talking about lupus and contraception, which is an extremely important topic. And why is this specifically important to highlight in the context of lupus? There are 2 key reasons. The first is that many of the medications that we commonly use to treat lupus are teratogenic, which means that they can harm a developing fetus if taken during a pregnancy. So contraception is important in that context. And when lupus is active, the risks of complications during a pregnancy are especially high. And so the use of effective contraception for pregnancy prevention and for timing pregnancy for the safest time for both mother and baby is extremely important. And thankfully, there are many contraceptive methods that are safe and effective for patients with lupus, and we'll get into some detail on that. But I'll note that while condoms are very important, as I mentioned, and the only method that reliably prevents sexually transmitted infections, they're not good enough as a sole measure to prevent pregnancy. So I like to show this graphic that comes from the CDC as a sort of overview and refresher about the many forms of contraception that are available. And these are organized according to the efficacy, the effectiveness in preventing pregnancy. So on the bottom tier in terms of effectiveness, there's condoms. And I would actually put the diaphragm on the bottom tier. They put it in the middle, but I would say anything with greater than 10%. Failure rate with typical use belongs down here. So diaphragm, condoms, the withdrawal method, sponge, spermicide, and fertility awareness-based methods are just tracking the cycle to avoid periods of ovulation. With typical use over the course of a year, 18 or more pregnancies will occur per 100 women. So that's really quite high. Then on the middle tier, excluding the diaphragm, you have the injectable, which is commonly referred to as the Depot shot or Depo-Provera, an every 3-month injection. The pill, and there are many varieties that are available, the patch, which is also a hormonal patch, and the vaginal ring. These all are moderately effective methods, meaning that they're, so I'll say 6 to 9 or less than 10% failure rate. So 6 to 9 pregnancies per 100 women with typical use over the course of a year. So still higher than you may think. And then on the top tier, on the top right, there's permanent sterilization. So we're not really focusing on this as much because this is not really in the context of future family planning. But in terms of reversible methods, you have the subdermal implant, which is inserted under the skin of the arm and then can stay in place for several years, and intrauterine device, or IUD, which is inserted into the uterine cavity and then can also stay there. So these are highly effective, don't have any user dependence, we like to say. So meaning you don't have to think about it. There's no real variation, typical versus perfect use. And as a result, less than 1 pregnancy per 100 women in the course of a year. So focusing on lupus, our next myth is that birth control pills are not safe for people with lupus. And this is important to highlight because this has not always been the way. Historically, rheumatologists and other doctors really didn't feel comfortable prescribing birth control pills for people with lupus. But we have some more reassuring research now where we can personalize our recommendations more, and there are many safe options in most contexts. But before getting into that, I always like to really highlight that all of the highly effective, so that's the IUD and the subdermal implant, all of the highly effective contraceptive options are safe for people with lupus with no caveats. So that's sort of a win-win. There are some scenarios in which we do recommend avoiding certain estrogen-containing contraceptive options that are in the moderately effective category. And these are for people with antiphospholipid antibodies or antiphospholipid syndrome. And I'll give a little more information in coming slides for anyone who's not familiar with these terms, or for patients with active or flaring lupus. And then in general, we do still recommend that people with lupus avoid using the hormone patch. And this is really because we just don't have specific research to assure us that it's safe and a higher level of estrogen is delivered through this mechanism as compared with the pill or other forms that we are comfortable with. So while we don't have the data to confirm its safety, we recommend avoiding. Another special scenario is for patients taking mycophenolate, or Cellcept or Myfortic are common brand names for this medication. This medication may make birth control pills less effective. So it doesn't mean that birth control pills are not an option, but we generally recommend a second method. So condoms in addition to birth control pills, if this is the preferred method for someone taking this medication. So a little more information on antiphospholipid syndrome. So people with lupus, commonly, and about a third of people with lupus may have antiphospholipid antibodies, which is something checked in the blood. And the names for the 3 main categories of antiphospholipid antibodies that we worry about are lupus anticoagulant, anticardiolipin antibodies, and anti-beta-2 glycoprotein 1 antibodies. And so persistent elevation above a set threshold, so not any abnormal, but persistent high level of any of these antibodies is associated with a risk of blood clots and certain pregnancy complications. And then antiphospholipid syndrome is a diagnosis given to people who have these antibodies at a high level persistently and also have had a complication related to these antibodies. And people who have antiphospholipid syndrome are treated with blood thinners or anticoagulation. And so this is a group where we worry more about the potential increased risk of blood clots associated with those estrogen-containing birth control methods. And then I said the other category where we pause is people with lupus that's active. So how can we tell if lupus is active? Well, first and foremost, we investigate symptoms. So because I said at the beginning that lupus, can manifest differently for each patient. No 2 lupus patients are the same. The symptoms can vary from one patient to another that may be indicative of active disease, but we worry when typical flare symptoms for a given patient are recurring, or when any of the symptoms on this list, which I'm not going to read through, but arise, then we start to worry about disease activity. And we also look at blood and urine tests that may be indicative of lupus activity. And some of these may be relevant for one patient, but not for another, like I said. So these include abnormal blood cell counts, low red blood cells or anemia, low white blood cells or leukopenia or lymphopenia, which refers to a certain type of white blood cell, thrombocytopenia or low platelets. We also look at general markers of inflammation, ESR and CRP, which can be elevated in the context of flare. And we also look at lupus-specific markers of inflammation, which can be low complement levels, C3 and C4, or in some patients, double-stranded DNA antibody levels can be elevated. And lastly, we look at markers of kidney disease in lupus, which can be an increased blood level of creatinine, increased urine protein, cells in the urine that or casts in the urine. And so just to recap and also to share with you what I think is a really great resource to be aware of. This comes from Bedsider, an organization that partnered with the American College of Rheumatology and has really great and reliable information for patients with rheumatic disease, including lupus, related to contraception. So the main takeaways from this graphic are sort of summarizing what we've just gone through, that these methods up top and over here on the top left are the highly effective methods. They're safe for all. And then also safe for all, the progestin only, mini pill, condom, and pulling out. But again, these aren't as effective as the ones on the left. And then this middle category, they call safe for most. So the shot, the ring, the pill, the combined estrogen progestin pill, there are those caveats, but they are safe for most. And then the patch is in its own category, where we generally avoid in lupus or for patients who have antiphospholipid antibodies, whether or not they have lupus. And again, that's because of concern for a potential increased risk of clot or disease flare and sort of inadequate research at this point. And then this also comes from Bedsider, and I think is an important topic to highlight, another one that's often overlooked or not addressed by doctors, and maybe patients don't always ask their doctor about emergency contraception. So if you take anything away from this, I think a really important takeaway from this talk is that all types of emergency contraception are safe with rheumatic disease, including lupus, including antiphospholipid syndrome. And these are sort of time-sensitive decisions where the stakes of not proceeding with emergency contraception, while it wouldn't be the best long-term preventive measure, the stakes can be really high. And so it's important to debunk any misconceptions about their safety in the context of lupus. Okay, so moving on from contraception, we'll talk a bit about fertility and start with a myth that people with lupus can't get pregnant. And this is also, there's some historical context here as well, because decades ago, before we had this whole body of research that we now have and more experience, doctors were telling their lupus patients that they might have difficulty getting pregnant, and more specifically, which we'll get to next, that they shouldn't get pregnant. So spoiler alert on the next myth, but most research really does not support the idea that lupus causes infertility. However, there are many factors related to having lupus that can impact one's ability to get pregnant or may lead to a decreased family size relative to peers. And these are shown, some of these are shown in this graphic, including advanced age, which may have disproportionate effect on lupus patients if they delay pregnancy for disease-related factors, psychosocial factors, menstrual irregularities, which we talked about, cytotoxic medications, which I'll get into a bit more, other medications that may interfere with ovulation and delay conception, even if they're not directly cytotoxic or directly sort of impacting ovarian reserve. And then having antiphospholipid syndrome is thought to potentially be an additional risk factor for impaired fertility, which can co-occur with lupus. And also there's some research on local autoimmunity that may impair fertility or conception. So more on medications and fertility. Cyclophosphamide, which is one of the medications used typically for severe manifestations of lupus, is infamous for its potential impact on fertility, both for males and for females. But it's not a one-to-one relationship, meaning getting a dose of like cyclophosphamide doesn't necessarily mean that there'll be any impact on future fertility. There are but with cumulative dose and so increased exposure over time, that risk does go up. And for females, there's research showing that receiving cyclophosphamide at an older age relative to younger age adds to this risk. There are some treatments available that we can give sort of timed specifically during a cycle with cyclophosphamide that can decrease the risk of future impaired fertility. Sulfasalazine is another medication we use to treat rheumatic disease, a little less commonly used in the context of lupus, although sometimes it can be used. And this is known to cause reversible azoospermia or decreased sperm count. So this doesn't occur in everyone and it's reversible. So the general recommendation is that if a man is unable to conceive with a partner while taking sulfasalazine, that the medication be stopped for 3 months, and then a semen analysis can be checked and can go from there, but the sperm counts should recover. NSAIDs, which refers to commonly over-the-counter medications such as Motrin, Advil, Naproxen, Aleve. There are a long list of NSAIDs that you may be familiar with. These can actually lead to a temporary reduction in ovulation and decrease in sperm generation. And so this is really important to know about as a patient because, again, these are over the counter. So we don't always know that our patients are taking these medications and they may not know that there could be this risk associated, but this is temporary. And also high dose steroids can temporarily interfere with ovulation and menstruation. So what about treatments for fertility concerns? So oocyte cryopreservation, or commonly known as egg freezing, is a great option for people who may need ongoing cyclophosphamide treatment or who may want or need to delay childbearing for any reason, disease-related or not, as a way to preserve future fertility. And in vitro fertilization, or IVF, may be an option for people with lupus facing infertility or considering gestational surrogacy or gestational carrier, which may be a consideration in rare cases for disease-related reasons or others. And so the takeaway here is that ovulation induction and egg retrieval, which are the procedures one undergoes prior to IVF, and also for the purposes of egg freezing, are generally considered to be safe. There are a couple caveats here that we do recommend waiting until lupus is controlled before undergoing these procedures because they do involve high doses of hormones that could have potential risks associated with them in the context of active or flaring lupus. And for people with antiphospholipid antibodies at high levels persistently, we do recommend consideration of treatment with blood thinners or anticoagulation in the context of undergoing ovulation induction and egg retrieval. Okay, so I gave that spoiler about another myth with some historical significance, that people with lupus shouldn't get pregnant. And this is really, what doctors used to tell their patients decades ago. And thankfully, we can debunk this as a general rule, but it is worth discussing that women with lupus do have an increased risk of certain pregnancy complications, including miscarriage, preeclampsia, growth restriction, and preterm delivery. But as with everything related to lupus, there's no sort of one size fits all in terms of talking about risk. There are certain specific risk factors that are associated with these outcomes. So of course, teratogenic medication use, using medications that are known to have a high rate of causing miscarriage or congenital anomalies. So we do everything we can to avoid unplanned pregnancies while patients are taking these medications. And then having active disease at the time of conception or shortly preceding conception increases the risk of maternal and fetal pregnancy complications. Having kidney disease, especially current and active disease, but also having a history of kidney disease, does put you in a slightly higher risk bucket than someone without kidney disease. and having antiphospholipid antibodies or antiphospholipid syndrome certainly increases the risk of some of these complications. And also certain other autoantibodies that I haven't yet mentioned, and I'll give a little more information about, called Sjogren's antibodies or anti-Ro or anti-LA antibodies, are associated with specific pregnancy complications. But the reassuring fact is that many women with lupus can have safe and successful pregnancies, especially when we're able to mitigate some of these known risk factors. So that means pursuing pregnancy when disease is well controlled on pregnancy compatible medications for at least 6 months prior to conception. And ensuring close monitoring by a rheumatologist and a high-risk obstetrician, and ideally with communication between the two and whoever else needs to be on your medical team. So this is sort of a bare bones lupus and pregnancy checklist that summarizes some of the points we've already gone over. So first, it's important to have a preconception counseling visit, and this can often be done virtually nowadays with a high-risk obstetrician or maternal fetal medicine doctor, so that you can understand your individual risks before trying to conceive, ideally. And having a plan for monitoring and communication with your rheumatologist before, during, and after pregnancy. And then we think about, for each individual, do they have severe organ involvement of their lupus or damage from their lupus that increases or changes their risk considerations? What is the status of their disease? Is it currently active and flaring, in which case we wouldn't recommend proceeding with pregnancy, or has it been active recently? What medications are you taking, and are these compatible with pregnancy? Could they be continued throughout pregnancy, or do they need to be changed? And then what are your specific autoantibodies, because each lupus patient may have different autoantibodies with different related risks. And lastly, whether you have neck or hip arthritis. And this is more thinking down the road to delivery considerations, because severe neck arthritis, which is not so common in lupus, may be something to discuss with an anesthesia team, and this is sort of niche. But then hip arthritis or avascular necrosis, osteonecrosis of the hip, which can happen, unfortunately, in lupus, may be a consideration when determining whether vaginal versus C-section delivery would be appropriate. Okay, so I'll take a break from talking for a few minutes and show you this video, a few minutes, where that gives a good example of sort of an ideal interaction between a patient with lupus who's considering pregnancy and their rheumatologist. And I think it will also sort of reinforce and summarize some of what we've talked about.
Noelle. Noelle is 33 years old and has lupus. She and her partner want to get pregnant, so she made an appointment with her rheumatologist to talk about how she needs to manage lupus in order to have a safe and healthy pregnancy.
Hi, Noelle.
Oh, I'm sorry.
So great to see you. I hear that you would like to become pregnant in the next year. Is that correct?
Yes, my partner and I want to have a baby soon. I feel pretty good, but I'm really worried about how lupus could impact my chances. I read so many scary things online about women with lupus not being able to get pregnant or having problems during pregnancy. Are there ways to have a safe and successful pregnancy?
Thank you for sharing your concerns with me. The good news is that having a plan will improve your chances of having a successful pregnancy. So I am glad we are talking about this. There are a couple of key points for us to discuss. Keeping lupus well controlled during pregnancy is important, both for yours and the baby's health. In general, well controlled means that you haven't had a flare on pregnancy-safe medications for at least 6 months. We also want to think about any other medical issues: high blood pressure, kidney disease, diabetes, antiphospholipid syndrome, to name a few, and how they might impact a pregnancy. If the lupus is well controlled prior to getting pregnant, you will be less likely to have pregnancy complications or disease flares during pregnancy.
What about my medications? Are they safe for pregnancy?
All right, so I see that you are still taking your hydroxychloroquine and mycophenolate. I recommend staying on the hydroxychloroquine. The drug is safe and may potentially decrease the risk for lupus flares and blood clots during pregnancy. It also may decrease the risk of your baby having a condition called neonatal lupus. However, mycophenolate is not safe in pregnancy. We should transition you to another medication that is safe for pregnancy and the baby, such as azathioprine. It will also be important for you to take low-dose aspirin, which is 81 milligrams, and prenatal vitamins. We will monitor for any lupus flares during that transition. Let's think about your timeline and what that might mean for you. Have you talked with your other healthcare providers about your desires to get pregnant soon? Having a team of medical providers will be helpful during this journey, as you will likely be seeing me, a rheumatologist, an OB/GYN with expertise in lupus pregnancies, and because you have a history of kidney disease, a nephrologist.
I've mentioned it, but haven't talked with them in a lot of detail. Do they know about the pregnancy-safe lupus medications and that I should wait until 6 months without a lupus flare? Is there information I can send them?
Great question. The American College of Rheumatology published reproductive health guidelines in 2020. They're available online for free and outline recommendations for medications and everything we are talking about. They also provide guidance on what lab tests are important.
This all sounds good. I still can't help but worry. What if I have trouble? And what if this just doesn't work out for me? I have good support at home from my family and friends, but what if I can't get pregnant?
I understand your concern. If we get to a point where you are having difficulty getting pregnant, there are other options. In vitro fertilization, surrogacy, and adoption are options you may wish to explore.
Okay, that makes me feel better. So it has been a couple of months since I've had a flare, which is good. It sounds like my next steps are make sure my doctors know I'm planning for pregnancy and tell them about the ACR reproductive health guidelines, review my medication and over-the-counter vitamins and supplements list, and transition to medications that are safe for pregnancy and safe for the baby. Be sure lupus is as well controlled as possible on this new medication, azathioprine, for at least 6 months, then try to get pregnant.
Yes, those are your next steps. And please call me at any time if you have a question or a new symptom.
If you are currently pregnant and were not able to plan in advance, it's not too late. Speak with your rheumatologist and OB/GYN now about next steps so you can have the best chance of a safe and healthy pregnancy.
Okay. So hopefully, again, that reinforced some some of the key points we've gone over so far. And a few more more things to talk about in terms of general management of lupus during pregnancy. So this was mentioned in the video that hydroxychloroquine or Plaquenil is recommended for use throughout pregnancy in all women with lupus. And so this is even for if you're not taking Plaquenil outside of pregnancy, we generally recommend starting it unless you have an allergy or a specific contraindication to using it. Low-dose aspirin is also generally recommended for all women with lupus during pregnancy, as it's known to decrease the risk of preeclampsia. And then in terms of monitoring, women with lupus have additional ultrasounds to monitor the baby's growth during the 3rd trimester because of that increased risk of growth restriction. There are also some individualized considerations. So I alluded to this on a previous slide that Sjogren's antibodies or Rho and LA antibodies, which may be present in some patients with lupus, confer a specific risk of having a baby with neonatal lupus. And I say so-called neonatal lupus because it's actually not the same as the baby being born with lupus. This is typically a temporary condition characterized by rash, certain lab abnormalities that generally go away by 3 months of age. But there is a very rare risk associated with these antibodies of congenital heart block, which this is can progress to significant and permanent damage to the baby's heart that can be very dangerous. And so in patients who have these antibodies, in addition to recommending the hydroxychloroquine, we recommend additional monitoring during the pregnancy with ultrasounds of the baby's heart. And the hydroxychloroquine in this context actually decreases the risk of congenital heart block from 2% among people with these antibodies to 1%. So it's a pretty significant risk reduction. And then I mentioned earlier that with antiphospholipid syndrome, there is one type of antiphospholipid syndrome that we refer to as obstetric APS for patients who have antiphospholipid antibodies and have had a prior pregnancy complication attributed to those antibodies. And for these patients, we recommend low dose Lovenox or heparin products during pregnancy to decrease associated risk of pregnancy complications. And then for people with the thrombotic variant of antiphospholipid syndrome, where they've had a prior blood clot, they should continue treatment with full dose anticoagulation, and that's going to be Lovenox or heparin in the context of pregnancy. So this is another resource that will be linked to later, so you can go back to it. But in terms of medications commonly used to treat lupus and their safety profile in pregnancy, and the good news is that there's a long list of pregnancy compatible medications here, and common ones that we've mentioned, hydroxychloroquine and also azathioprine, I would highlight and was highlighted in the video as a common sort of immunosuppressive medication that we'll use during pregnancy. And then there's also a list to be aware of medications that are known to be teratogenic and should not be taken in the context of pregnancy. And we've talked about some of these. In terms of breastfeeding, there's some overlap here, but it's not exactly one-to-one in terms of pregnancy safety and breastfeeding safety. Cyclophosphamide, methotrexate, mycophenolate, Cellcept, and Myfortic are not considered to be safe during breastfeeding. But this long list of medications here, which I won't read off, but you'll have access to, is compatible with breastfeeding, so shouldn't be a barrier to breastfeeding for patients who need those medications. So I think an important point to mention, and potentially, on the list of the most important ways to mitigate your risks associated with pregnancy and throughout pregnancy, is to communicate with your doctor. And this really applies to not just pregnancy, but all sexual and reproductive health care in the context of having lupus, is to strive for open communication with you and your doctor, to discuss active symptoms, share all information that may or may not be relevant, and it's not your job to figure out if it is relevant, and to ask questions. And if a recommendation doesn't feel right, then be open about your concerns or potential barriers to proceeding with that recommendation, because it's better to be open about that than just to sort of make a different decision. Often there are available alternatives. So I'll end there. And again, you'll have access to these, but these are some great resources to be aware of. That so the HSS Rheumatology Reproductive Health Program, which I'm a part of, we have a website that lists the other rheumatologists at HSS who specialize in this area and also has some educational content. HopStep is a great website through Duke with a very easy to remember URL, lupuspregnancy.org, that has a lot of great video content for patients, information for providers. You can direct your provider to this website as well about lupus and pregnancy. And then Bedsider is that resource that I mentioned that has contraception information, and a lot of it is available in both English and Spanish. So that's great to know about as well. So thank you again for your attention, and I welcome any questions or comments.
Thank you, Dr. Siegel. That was a really comprehensive presentation, so thank you so much. At this time, I'd like to transition over to the question and answer portion of our program. So just a friendly reminder, we're gonna just use the chat box to feature and to submit some of your questions so Dr. Siegel can answer them this evening. I'm going to begin with, a lot of you had submitted a lot of questions prior to the presentation. So we'll also check the chat box for your live questions during this time. So any of the questions that were submitted previously, will be being grouped together. So that way we can get through as many questions as possible. We want to make sure we get to all your questions, and we're committed to providing you with an answer. So first question that we have is, does a lupus affect one's libido?
So yes, thank you for this question. And I mentioned briefly early in the talk about the part about sexual health, sexual dysfunction. And there is some research suggesting a link between lupus and decreased libido. But really the research is pretty limited in this area. So, more research should be done to confirm that association, and also sort of tease out what's underlying it, because there's a lot of indirect factors, or sort of factors related to having lupus that can impact libido as well. And so it's really important though to bring this up with your individual provider, so that you can, like everything else, you can understand what may be contributing in your case and sort of how to address that.
We have a couple questions about CellCept. So what is the approximate time frame one should stop taking CellCept to plan for pregnancy? And once you, and I'll just do it as a two-part, how long after taking CellCept is it safe to get pregnant?
Yeah, this is a great question and a really important one. So thank you for everyone who asked it. One thing I should say and make very clear is that if you're on CellCept or any of the medications that are in the no-go list for pregnancy, you should communicate with your doctor and not just stop it and then try to get pregnant. Because often if you need one of those medications, you may need a replacement. So I think the video sort of highlights that, but just to emphasize that, because it's really important. So, so the general recommendation is to wait at least 6 weeks since being on CellCept before trying to conceive. Although in practice, a lot of the time we recommend longer, because if you think about it, we're recommending in a lot of cases that someone switch from CellCept to something like azathioprine. Then, it takes, a few months to both get to the optimal dose of azathioprine, make sure that you're not having side effects with the azathioprine and that it's controlling the disease. And we really want to see 6 months of stable disease on a pregnancy compatible medication before we would feel comfortable, recommending that you try to conceive. So it ends up in practice being a lot longer usually than 6 weeks.
So I think you touched upon a little bit of this before during your talk, but how much more difficult is it to get pregnant and stay pregnant for someone with lupus?
Yeah, this is a great question, but also a really tough one to give any sort of blanket answer, because there's so many factors that contribute to one's success rate in terms of getting pregnant and staying pregnant. So I'm not going to be able to quote you any neat numbers or simple responses, but I think the main takeaway that I'll just sort of repeat is that for someone with lupus who has stable disease and is on pregnancy compatible medications, the chances of a successful pregnancy are good. Yes, there are always difficult to quantify, but there's always going to be some increased risk relative to someone without lupus of some of these pregnancy complications. And that's the reason why we recommend extra monitoring, and we recommend low dose aspirin and hydroxychloroquine to do everything we can to decrease those risks. But if we're doing all of that and you have a team monitoring you over the course of a pregnancy, staying pregnant, chances are good. And similarly, I mentioned this in the context of getting pregnant and sort of fertility impairment with lupus. There's a lot of research that suggests that just having lupus in and of itself does not significantly impair one's fertility or likelihood of getting pregnant, to that part of the question. But there may be many factors for different people that that could contribute to impaired fertility or more difficulty getting pregnant. So not the most satisfying answer, but it's the best I can really give. But speaking to your doctor will give you a better sense of how that applies to you.
Next question we have, can women with lupus get married and have a normal sex life?
Easy answer to that is yes. But as I've, talked about during this talk, and even in that response, there are many things that can affect, sexual function and these can be related to lupus. So, but overall, it is a definite possibility to have a normal sex life with lupus.
What are the odds of having a second healthy pregnancy within 2 years of a first healthy pregnancy at age 39 to 40 with lupus?
Yeah, so thank you for this question. And I think independently of any chronic disease, including lupus, age is a big factor in terms of fertility. And so that's no different, again, if you have lupus or you don't, but it is different by individual. So, you know, fertility at age 39 or 40 is less in general than at a lower age, but many women still do get pregnant at 39 or 40. But again, so I think, you know, to get a more individualized answer to that would require speaking with a doctor to assess your other risk factors if you have any. And then, you know, I will say that having one successful pregnancy is generally considered to be a good sign in terms of the ability to have another successful pregnancy. Of course, the age factor does play in, but in terms of the other risks, it's not a sure thing, but it is a good sign that about one's fertility and also about other risk factors and complications that can arise during pregnancy.
This is a similar question, so I'm gonna set, this is in the chat box, so thank you for actually putting that in there. So basically, when should a person consider other options to getting pregnant? 6 months, a year after trying, or 18 months?
Yeah, so I think this question is about difficulty conceiving and sort of when to seek evaluation for this. If that's the question, I think that it depends a bit on your age and other risk factors. The general teaching, and I'm not an obstetrician gynecologist, I'm not a reproductive endocrinologist and infertility specialist, so I'll say that right off the bat. But in the general population, after 6 months of trying, if you're 35 and older, and after 1 year of trying, if you're younger than 35, it's generally recommended to seek evaluation from a fertility specialist. If you have other risk factors like lupus or other organ damage as a result of lupus that may make pregnancy more risky to begin with and may potentially have bearing on your fertility, it may be worth seeking that evaluation sooner, but I think that's a discussion to have with your doctor.
Okay, so I think we have time for a couple, like 3 or 4 more questions. So I'm going to look at the chat for a minute. So I think, is sulfasalazine only impactful in fertility to males and not females?
Yeah, so yes, that's correct. It does have that temporary effect potentially of decreasing sperm count in males, but it is one of the medications that we consider to be safe to continue during pregnancy for females. And it does not, I'm not aware of evidence that it impacts ovarian reserve or in other ways would delay conception from the female side.
We have another medication question. Is I'm not even saying it correctly. I can't even say it. Azathioprine? Yeah, I'm saying it incorrectly. Is it safe for pregnancy? Why does the label always warn that patients should not be taking it while they're pregnant? I think you touched upon this before.
Yeah, so our evidence is really supportive. There is a good body of research that supports its safety in pregnancy. The sort of pregnancy risk classifications and labels that you'll see on medications shouldn't be discounted, and you should discuss with your doctor. But there may be a different threshold for sort of signals that need to be reported in that way versus what our guidelines support on the basis of, at this point, a good body of research and a lot of experience using it during pregnancy. So I would say, in general, we consider it compatible with pregnancy. Everything has potential rare risks, pregnancy or not. And so you have to keep that in mind.
And then one last question. Yesterday, my gynecologist suggested I seek family counseling because I had a blood clot in 2020 after having COVID as well, having lupus. So she said I'm a super anticoagulant, especially when I become pregnant, if I become pregnant. Am I classified as having APS, or is that in the same group because of my history?
Good question. So I'll presume, because I think you might have mentioned this, if it weren't the case that your antiphospholipids antibodies have not been positive, or maybe you're not sure, you would not have a diagnosis of APS without having confirmed persistent positive antiphospholipid antibodies, regardless of whether you've had a blood clot. So, but having a blood clot for any reason, may suggest that you have more risk than somebody else of developing a blood clot in the future. I mean, typically we'd recommend that you at least be evaluated for the things we can test for that can be associated with increased blood clots. In addition to antiphospholipid antibodies, there's a number of other things that a hematologist or another doctor may want to evaluate you for. But sometimes there's no clear risk factor, and something like COVID or taking birth control pill, outside of the context of lupus or with lupus, may lead to a blood clot in one person and not somebody else. And we don't know why. But I think that you're right to think that, and your doctor's right to think that you may be at increased risk of a blood clot during pregnancy, which is also a prothrombotic state, meaning in itself, pregnancy increases anyone's risk of blood clots because you've had a blood clot in the past. Whether or not that's reason to do anything differently, take any medications in pregnancy, like such as blood thinners. If you don't have antiphospholipid antibodies, there wouldn't be a guideline dictating that decision. It would be a personal decision based on your whole risk profile and discussion with your doctors and any further evaluation that maybe has or hasn't been done yet. So, but I do think it's worth sort of taking that event seriously in the context of family planning and seeking additional evaluation, just so you understand your risks and what may or may not be recommended to mitigate those risks.
Thanks, Dr. Siegel. I just wanted to thank Dr. Siegel today for her time and for all her great information, and also for all the questions that were asked and answered. So thank you. And I want to turn it over to Priscilla.